Morning, sir. We can hear you.
Okay, so today our lecture is on jaundice. So basically, we have covered a few diseases so far, and we are basically trying to cover a clinical presentation today, a symptom or a sign. Sometimes it's a symptom because a patient might come and tell you that the patient has yellow eyes, or sometimes it can be a physical sign because when we examine the patient, we might find that the patient's eyes are yellow or even the skin is yellow. So I'm actually talking to you from the point of view of that particular point when we discover the patient is jaundiced. The definition of jaundice is the yellowish discoloration of tissues due to increased serum bilirubin. So you first see that the tissues are discolored in a sort of a yellowish color. And then you also need to confirm that with a serum bilirubin level. But before the patient is found to have increased serum bilirubin, you can say that the patient is icteric, because it's generally a very characteristic appearance, so therefore it's not a difficult thing. It is best seen on the sclera, the white of the eye, and under the tongue. That is, you ask the patient to open the mouth and lift the tongue up and look at the mucosa below the tongue. But you sometimes have to use natural light, because if you look at the sclera or under the tongue using the light that is given by the fluorescent lights, especially, you might miss jaundice. Sometimes not just mild jaundice, but even moderate jaundice can be missed by looking at it through these lights. So we must be careful when we are examining patients inside our clinics or consultation rooms or dispensaries and so on, because we normally use fluorescent light because of the fact that it is cheaper with regard to electricity consumption. So we must make sure that there's a window close by with sunlight, where we'll have to sometimes take the patient to the window and ask the patient to look out of the window and look at it with natural light. Otherwise, you can miss it. And of course, the normal serum bilirubin is below 3 milligrams per deciliter. So this yellowish discoloration, when we first see it, has to be separated from or differentiated from two conditions. Actually, one condition, the other one is rare. The common condition is carotenoderma. That is the deposition of carotene or vitamin A in the skin. So this is seen especially during times when people consume lots of carotene-containing foods, and the favorite is mangoes. So, for example, if you go to in the Jaffna Peninsula during the mango season, there are lots of mango trees, and children during the New Year holidays, they are at home and they climb these trees and they eat mangoes one after the other. In fact, even in our childhood, we used to do it in Colombo also, because there were mango trees those days, unlike now. And sometimes they eat mangoes from morning till evening, and they can get yellow. The skin can become yellow, but this spares the white of the eye, the sclera. The sclera remains white. So this yellowness mostly appears on the palms and the soles, and the forehead and the nasolabial folds. There's a medication called quinacrine, which is now obsolete, but that also used to cause yellow discoloration, including the eyes. Let me revise with you a little bit of the bilirubin metabolism. You know that bilirubin is formed from heme breakdown. That is because the heme molecule, which is very important for interacting with oxygen, cannot be reused. When the cell becomes old and the cell is broken down, the body does not have the ability to reuse the heme that is in it, because we don't have the enzymes. So the heme is also broken down. But when the heme molecule is broken up, it produces very toxic molecules like biliverdin and so on. And these are very toxic to the cell. So what the cell does is it immediately converts that into bilirubin, which is a little less toxic, and then excretes that into the ECF to get rid of it. And even in the ECF, it should not remain for long, because even the bilirubin in the ECF is harmful to cells, so it must be taken out of the body quickly. So the sources of heme, the most important source is red cells, So senescent or old red cells are broken down. And also even in the bone marrow, there's something called ineffective erythropoiesis, which basically means all our erythropoiesis don't produce proper good red cells. Sometimes a small percentage of red cells are useless. So those red cells are not released into the body, into the bloodstream. In the bone marrow itself, they are broken down before they are released, so that ineffective erythropoiesis red cells are they don't enter the circulation. So that is the most important contribution of heme from old red cells, which are broken down, especially in the spleen, and also ineffective red cells made during erythropoiesis in the bone marrow. Then heme is also found in the myoglobin of muscles, and that is also another source of heme and the breakdown, and also found in the cytochromes of the mitochondria and so on in normal cells also. So these are the sources of heme, and when they are broken doin, they produce the biliverdin, which is very toxic, and that converts to bilirubin, which is also less toxic but still very toxic, and therefore that must be taken away from the body. So this is immediately transported to the liver bound to albumin. This is unconjugated bilirubin. And in the liver, it is taken up by the liver cell and conjugated to glucuronic acid to produce bilirubin glucuronide, and that's called conjugated bilirubin. And this is excreted in the bile canaliculi into the bile. Now, you might wonder, why is it that unconjugated bilirubin is conjugated before excretion? That is a very common thing that the liver does. Whenever the liver sees a molecule which it has to get rid of from the body, which is lipid soluble, there's no point giving it out into the bile in the same form, because if it remains lipid soluble in the bile and goes into the intestine, you know that lipid soluble substances are very well absorbed in the intestinal tract, GI tract. So therefore it will be reabsorbed. So if it is a molecule that you want to get rid of, and if it is lipid soluble, there's no point putting it into the bile in the same form. You have to make it water soluble so that it won't be reabsorbed. And that is why it is conjugated with glucuronic acid, because when it's conjugated with glucuronic acid, the molecule becomes water soluble. Actually, this is done not only for bilirubin, it's done for any large molecular weight molecule which is lipid soluble, which the body is trying to get rid of. For example, hormones are there, sometimes medications, drugs are there. All these things that the liver wants to get rid of and is large molecular weight. Why I say large molecular weight is because if it is small molecular weight, you can probably get rid of it in the kidney also through filtration. But if it is large molecular weight, it won't be filtered, because there is a limit to the molecular weight that can be filtered. So if it is large molecular weight and lipid soluble, they are all conjugated before excretion in the bile. But in the bowel, some more things happen. There is bacteria which deconjugate these conjugated bilirubin, which is of course not good for us, but you know what to do. There are bacteria in the colon and so on. And they have deconjugating enzymes, and a certain proportion of this is unconjugated, and therefore bilirubin is reformed. Now, there is bacteria which also oxidize the bilirubin, giving rise to what is called stercobilinogen. Now, stercobilinogen is called bile pigment, and that is absorbed because it is what lipid soluble, deconjugated and oxidized, lipid soluble, and it enters the portal system. So, the stercobilinogen, which is colorless, if that is oxidized when you're exposed to oxygen, it produces stercobilin, which is colored, which has a brownish reddish sort of color. Now, stercobilin is excreted in the feces, but is not absorbed, is oxidized and excreted in the feces, giving rise to the characteristic color of the feces, the brownish yellow color. But some stercobilinogen is absorbed into the portal circulation, and the liver can reuptake them and re-excrete them into the bile. That's called the enterohepatic circulation of bile pigments. In fact, the liver is able to reabsorb and resecrete many substances which are deconjugated like that. So there is a enterohepatic circulation of many substances. One of them is bile pigments. Now, some of the absorbed stercobilinogen escapes getting re-excreted in the bile, and that enters the systemic circulation, and then they are filtered in the urine, and that is called urobilinogen. It is the same molecule with a different name, urobilinogen, and that is in the bladder and then goes in the urine. And once they come out of the urine, it gets exposed to oxygen and becomes oxidized and becomes a color and darker color urobilin. So you will see, for example, if you pass urine to the commode, when you pass the urine, it's slightly yellow. And then if you wait for about a minute before flushing the toilet, you will find that the slight yellowness has become darker, become almost orange. That is because in that 1 minute or so, the urobilinogen that was in the urine has become exposed to oxygen and got converted to urobilin and therefore become darker. Now you might think that the yellowness in the urine is also because of that same thing, but actually no. The yellow color of the urine when you pass it fresh is not due to urobilin because it's not yet oxidized. And it's not due to urobilinogen because urobilinogen is colorless. It's because of various other pigments. They have various names like uroerythrin, urochrome, and so on. They are not important, but the color comes from this. And nowadays, of course, both strocobilin and strocobilinogen and urobilin and urobilinogen are given the same name. They are both called urobilin or urobilinogen. But it is all right to use the word strocobilin or strocobilinogen also if you like. Right. So this is the story of how bilirubin is got rid of from the body. Now, I'm going to talk about adults, of course, because you should know that in neonates, bilirubin is very toxic. You have heard about Conjugated and so on. I won't talk about that. So now, how do you approach an adult patient with increased bilirubin? The first question to ask is the patient's hyperbilirubinemia unconjugated or conjugated? So you can do that using clinical features as well as investigations. With regard to clinical features, if the patient is having deep jaundice and itching, that indicates cholestasis, and therefore it is conjugated. On the contrary, unconjugated bilirubin is not deep jaundice, it is mild to moderate jaundice, and there is no cholestasis. Therefore, there is no itching. Investigations wise, you can do a urine test. If the urine has bile and bilirubin, that indicates cholestasis because only conjugated bilirubin and bile can go in the urine, whereas unconjugated bilirubin cannot appear in the urine because it is bound to albumin and therefore it's not filtered into the glomerulus. So if there's on a urine full report, if there's bile and bilirubin, it is definitely conjugated hyperbilirubinemia and it indicates cholestasis. And also if the urine urobilin is increased, that means it's either early and recovery stages of cholestasis or hemolysis. So if there's hemolysis, there's increased urobilin in the urine. And if there's obstruction or cholestasis, also there's increased urobilin in the early stage of obstruction and recovery stage of obstruction. That is because when there's obstruction, just as the obstruction happens, the reabsorbed urobilin can't go in the liver and they all go in the urine and therefore it becomes increased. But after some time, because there's no bile coming into the intestine, there's no formation of new urobilin and therefore there's no urobilin thereafter in the urine also. When the patient starts to recover, the obstruction is relieved and bile re-enters the intestine and therefore there's resynthesis of urobilin and therefore it reappears in the urine. And also the other way to separate the conjugated and the unconjugated hyperbilirubinemia is to do a serum bilirubin fractions. That's very easy. But even without that, urine for bile, bilirubin, and urobilin, you can see whether it is unconjugated or conjugated. The next thing that you can do is check whether the liver profile is normal or abnormal. If the transaminases are elevated, that indicates hepatocellular injury. Therefore, it's probably due to a hepatitis or liver injury condition. So therefore, it's probably either hepatic or biliary. So therefore, it is conjugated. And if the alkaline phosphatase is elevated, it indicates cholestasis. But of course, you must keep in mind, like I said yesterday, that there are other reasons for the elevation of transaminases and alkaline phosphatase. Okay, if I talk about unconjugated hyperbilirubinemia, The most common cause is hemolysis or ineffective erythropoiesis. Here, the patient, if you look at the sclera, they'll be pallor because of anemia, as well as a lemon yellow tinge. That means a very light yellowness to the sclera. Uh, the patient will also have a low hemoglobin, increased MCV because of hemolysis, and reticulocytosis. And there's increased urine urobilin in the urine, and the liver profile is normal, except that sometimes there can be a slightly high AST because of hemolysis. Unconjugated hyperbilirubinemia can also be because of problems within the liver, and probably the commonest is Gilbert syndrome, which is a common variant, normal variant. And the next most common reason is probably the medication called rifampicin, which is an anti-TB medication which produces unconjugated hyperbilirubinemia. There is a condition called Crigler-Najjar syndrome, which is inherited genetic problem, which is very rare. So about Gilbert syndrome, it's seen in around 8% of the population, males more than females. So I suppose if you take your batch, although there are about 200, I don't expect there will be 16 people with Gilbert syndrome because most of you are female. Is that right? No, actually it's not right, no, because it will be 60% of the batch will be having that probably. No, I think it will be probably less than 16 because when you say 8% of the population, it's a general population. No? So there the male and female ratio will be 1:1, whereas in a batch there are more females, about almost 2/3 are females. So therefore, it won't be 8% of your batch; it will be a little less than that, mostly males. So here the bilirubin is increased by fasting, by fatigue, alcohol, intercurrent illnesses like febrile illnesses, and by taking this medication called nicotinic acid, which is sometimes given for dyslipidemias, and decreased by taking calories, opposite of fasting, or by enzyme inducers, especially phenobarbital. So this is a condition that often happens during intercurrent illnesses or during fasting. The patient becomes yellowish in the eyes, and then after the patient eats something, it goes away. Or after the patient recovers from the acute illness, the yellowness goes away. So it's a very temporary thing, and they hardly ever come to you. They might be picked up accidentally because of a routine blood test, or they might be picked up during the yellowness also. So when you see a patient with a unconjugated hyperbilirubinemia with a normal liver profile, uh, you should think about Gilbert syndrome also because it's a very common thing and it's a very benign thing. Now, sometimes you know that patients have to fast for lipid profiles for about 14 hours, 12 hours, 14 hours, and so on. So when they go to do a lipid profile and if they also do a liver profile at the same time, some of them will have a little bit of jaundice in that fasting sample. So don't rush and worry when you see a slightly elevated bilirubin in patients who have been fasting for the lipid profile. Just ask them to eat a good meal some other day and take another blood sample just for the bilirubin to see if it has become normalized. Especially if the liver profile is normal otherwise, then it's probably a Gilbert syndrome. Uh, some medications are contraindicated in Gilbert syndrome. There's a medication called irinotectin, which is, I think, a cancer drug. And some medications must be taken with caution, like menthol, which is given in various foods, estradiol benzoate, even paracetamol, tolbutamide, which is anti-diabetes medication, and rifampicin, which is anti-TB drug. So those ones should be, if possible, avoided in patients known to have Gilbert syndrome. Or if you use them, you should use a reduced dose, such as, for example, in the case of paracetamol, you can use 1 tablet 6 hourly rather than 2 tablets 6 hourly. Okay, so that's about unconjugated bilirubin. Let's talk about conjugated hyperbilirubinemia. This happens in cholestasis. And there's also, at the same time, there's also retention of bile salts, and that gives rise to itching. And also gives rise to increased serum alkaline phosphatase and 5-nucleotidase, as I said yesterday. And you'll also see increased urobilinogen or urobilin in the urine. because of the absorbed stock of bilinogen appearing in the urine. Now, in prolonged cholestasis, the conjugated bilirubin also binds to the albumin molecules in the blood, and that has been given a new name. It's called delta fraction of bilirubin. Now, this bilirubin has a half-life of albumin rather than bilirubin itself, and therefore this hyperbilirubinemia may persist even after the cholestasis has settled. So the half-life of bilirubin is about 4 hours, and the half-life of albumin is about 2 weeks. So once it has been prolonged, once the cholestasis has been there for about 2-3 weeks, then even though the cholestasis is corrected, the bilirubin remains elevated in the blood because it's now bound to albumin and it has to be got rid of in the same way that albumin is gotten rid of. So therefore, now we have a situation where there's conjugated hyperbilirubinemia plus absent urine urobilinogen because the cholestasis is now corrected. So you also have persistence of increased bilirubin and jaundice in spite of the recovery of the hepatic or the biliary disease. So if the patient is otherwise recovering from the hepatic or liver biliary disease, and if there's no urobilin in the urine, or no increased urobilin in the urine, then you don't have to worry about the bilirubin being elevated. You have to just be patient and watch a little bit more for the bilirubin to disappear gradually. Now, if there's a conjugated hyperbilirubinemia with an abnormal liver profile, most likely situation is it's either a liver disease or a biliary tract disease. And in that situation, the crucial investigation is the abdominal ultrasound scan because it is very sensitive to pick out biliary tract disease. Then you can differentiate the biliary tract disease from the liver disease. Okay, so that's the information I wanted to give you about jaundice. Do you have any questions? Okay, if there are no questions, I'll close the session. Thank you.
Thank you, sir.